Excuse me, Leonard Bowen.
So, so.
Thank
Okay, we'll start in a moment. seats left, so I was going to say take your seats, but there aren't any, I don't believe. All right, so I'm Brian Dury, and I'm very pleased to be able to welcome you to our 2015 meeting, Global Advances in Myeloma, Providing Best Options for Treatment. So we are very pleased to be able to put on this program. I'm the director of this program. The faculty is very, very strong this year, and I'll just introduce people from my left to further down the table. To my immediate left, I have Jesus San Miguel from the University of Navarra in Spain. To his left. Yeah. Yeah. So we'll see who gets the most initial votes here. To his left, we have Philippe Moreau from Nantes in France. Very pleased to have Philippe. Then we have Shaji Kumar from the Mayo Clinic in Rochester, Minnesota. And then we have Antonio Palumbo from Torino, Italy. And last but not least, we have Bruno Pavia from Pamplona in Spain. So Bruno, please welcome. All right.
The second one was wrong.
So you can see the agenda. We have picked 4 clinical situations that we think will lead to some very important educational points. We will first talk about the approach to early disease. Will new diagnostic criteria and early treatment improve survival, or possibly have a negative impact and result in more aggressive disease, relapse? Secondly, should risk-adapted therapy be used for patients with newly diagnosed myeloma? Thirdly, should minimal residual disease be used to guide treatment decisions regarding maintenance therapy? And finally, emerging systemic therapies. Is this a situation where best therapy should be used in newly diagnosed patients or reserved for the relapse disease setting? And so this is a particularly difficult question. First of all, we just wanted to acknowledge something that is really fantastic for the myeloma community, and that is that we just want to congratulate our pharma partners and many people in the room here who've been involved with the research that has led to this amazing approval of 3 new drugs just in this last month. Fantastic. And I bring this up in part because as a drug moves from research to approved, it appears differently in our treatment algorithms. And so we are struggling to react to that in the way that we've structured the debate. So just to let you know, with these recent approvals, we will be considering these new options, and you should too, as you see some of the questions that we pose to you, to be thinking about, in addition to the previously approved drugs, what about these newly approved drugs? I would just mention that daratumumab, Darzalex, is approved in the relapse refractory setting, and so would be a consideration in that setting. Ixazomib, Ninlaro, and elotuzumab, Implicity, are approved in the earlier relapse setting, and so could be considerations in that situation. But we're actually not so much focused on that in this particular debate session. Okay, so let's proceed with the first debate. As I mentioned, this will be: will new diagnostic criteria and early treatment improve survival or result in more aggressive disease at relapse? So, as an introduction, we give you a case example, and this is Mrs. Garcia, who had an erythrocyte sedimentation rate performed. So first of all, you have two clues there. It's Mrs. Garcia, and she had a SED rate performed. Where could that be possible? Maybe in Spain, I think. In the US, we don't do sedimentation rates too much anymore. But this 52-year-old lady had some testing done and was found to be not anemic, have a normal creatinine and calcium and liver function, did have a significant monoclonal protein, IgG kappa, 3.2 grams in the US system, 32 in the European system, 20% plasma cells, and 98% phenotypically aberrant, which feeds into the Spanish way of looking at these bone marrow findings. And then FISH analysis shows the translocation 414, but importantly, on a skeletal survey, there were no bone lesions found. So the first question, now, as you're just looking at this, just to be aware that the question is going to be, will you do any additional testing? So just have a last look at what you have on the screen there, and then as I switch to the question, it is, in your current clinical practice, would you perform additional testing to figure out what to do for Mrs. Garcia? So if we can ask this question first. Yes, if you, hopefully you have found your pads to answer the question. If not, you're probably sitting very uncomfortably. Okay, so in your current clinical practice, 78% of people say that they would, in fact, perform additional testing, and only 2% are unsure. So this is an important point. Okay, it's been pointed out to me that if you don't have it, it's hanging on the chair in front of you, or I guess for the front row, looks like most of the people in the front row have them, but anyway, they're hanging on the chairs. So let's turn to the second part of this question. So in your current clinical practice, would you consider such a patient to be a candidate for treatment? Yes, no, or only in a clinical trial, or unsure? So if we could answer that. Okay, so the top answer, 37%, is that 37% would in fact treat this patient, and 29% would in a trial, 25% no. So we have a very interesting debate coming up, and we will be asking this question again after the debate, and we'll see what is the impact of our two illustrious speakers. And so I'd first like to welcome Jesus San Miguel, who will present the case for the use of new diagnostic criteria and early treatment. Please welcome Jesus.
Thank you. Thank you very much, Brian. It's a great pleasure just to be with you today. Although I should confess that it's not a real pleasure. In fact, I called my mother 1 hour ago, and I told her, look, Mommy, I'm a bit nervous. I can't every day, and my opponent is Philippe Moreau. And, you know, he's very clever. He will pick up some tiny negative things from my presentation to criticize me, because he has a lot of genius. You know, my mother said, be relaxed. Remember the story of one friend of your father about Sophia Loren. Do you know Sophia Loren? You know, this friend of my father today used to say to my father, look, Sophia Loren, her feet are very big. They know. The nose is quite big. And the mouth is big. You know, but he likes very much Sophia Loren. Okay, the tiny things, the big things. Okay, this debate is about the first 3 topics to be discussed. First of all, do we have new criteria for myeloma? Recently, the International Myeloma Working Group has established that in the absence of CRAB symptoms, if the patient has more than 60% plasma cell in the bone marrow, a fill-light chain ratio over 100, and more than one focal lesion on MRI, this patient has more than 70% chances to progress within the first 2 years and should be considered as early myeloma. But this is not the only early marker, because until recently, we considered only bone lesion when they were detected by conventional X-ray. But we know that you need to lose at least 30% of the body mass to have a lytic lesion. By PET, you can, or CT PET, or CT, you can detect it this earlier. And the same applies for the creatinine. Until now, only creatinine more than 2. Now we know that the creatinine clearance of less than 40 is also a marker of deteriorated renal function. Then we have early markers that corresponded to what we previously called ultra-high risk. For the high this model is defined if the patient has more than and or more than 30 grams per liter, 3 grams per deciliter of the component. If you have both parameters, the risk of progression is 50% in the first 2 years, 70% in the first 3 years. The Spanish group has also identified another marker, that is the presence of almost virtually all the plasma cells with clonality. When they are, all the plasma cells are clonal, this is different from MGAS. In MGAS, you have clonal and polyclonal. In a smoldering, if all the plasma cells are clonal, then this is associated with a higher risk of progression. And there are also other factors, such as high risk cytogenetics or the presence of PET positive without lytic lesions. But the good news is that this is not the end of the story. We should work to try to identify better and better biomarkers, as Antonio Palumbo has mentioned several times, and one of the probably more promising is the presence of circulating plasma cells in the peripheral blood. The Mayo Clinic has shown that these patients has a median time to progression of just 1 year, and the Spanish group, under the umbrella of the Black Swan project, is working on the identification of what we call the myeloma profile for the smoldering. And these patients have a time to progression of 16 months. Then, the first question, we have markers, we are improving. Is this the end of the story? No, but we are in the way. The second question for the debate, will early treatment improve survival in myeloma patients? What do we know about early treatment, or to treat the disease when it's not so bulky? We have the international staging system, and this slide corresponded to more than 10,000 patients. And in this, it was clearly shown that both under standard or high-dose therapy, patients in stage 1 of the disease survive longer. Then, earlier stage of the disease is associated with much longer survival. In the era of novel agents, the Spanish group has reproduced, as the French group, Italian group, that stage 1 myeloma have significantly longer survival. Do we want to wait, if you have a stage 1, until they develop a stage 3? No, you treat a stage 1 because this is of benefit for the patient. What about smoldering myeloma patients? Until now, most studies have
not discriminate between the ultra-high risk, what we call early, the high risk, the conventional standard risk smoldering, and the low risk that are not really smoldering. These are M-gas. And all the efforts demonstrated little efficacy. Why this occur? Probably because they are including many of these patients in which the S phase, the proliferation of the cell, is so low that they will not respond to any treatment. And here, you are not getting any benefit. We decided to focus in this population, the high risk and in the ultra-high risk, defined with the old criteria, the Mayo and the Spanish criteria. And we conducted a randomized trial in which we compare lenalidomide dex versus abstention, no treatment, the standard of care, until progression into a clinical myeloma, a symptomatic myeloma. As you can see in the control arm, the median time to progression was less than 2 years, the expected one. This indicates that we have selected the correct population. Moreover, 85%, the vast majority of the patients have already progressed. By contrast, the situation is completely different, and this was the primary endpoint, that we demonstrate the treatment with lenalidomide dex reduced the hazard ratio to progression into clinical symptomatic disease by 6.1. Something that was unexpected in the trial is the overall survival. The trial was, the primary endpoint was PFS, as I mentioned, but we were surprised that right from the beginning we start to see difference in overall survival. And now, with a long follow-up of more than 60 months, we continue to observe a significant benefit in overall survival. Look, 95%, the vast majority, almost all the patients in the intervention arm are alive, while only 64% of the patients in the no treatment are alive. The next question in this debate was, early treatment may result in more aggressive disease at relapse. Could this be correct? We decided to analyze in this clinical trial the outcome of patients, the survival from the progression into active disease. And as you can see, even after this situation, the survival continued to be better for the Len-Dex. Here you have the results. Probably some of you may say, okay, it could be that in the control arm, you don't offer the patients an optimized treatment when they progress. This is the data. You look, a median age of 74 years, very advanced age, and they receive VMP, Len-Dex, even autologous transplant, only a small proportion MP, probably the very elderly patients. And in spite of this, these patients have, as you can see, only half of them are alive at 5 years after progression. What this indicates me? This indicates me that when you wait in the disease, you accumulate genetic lesions, and this is bad for the patient. And this is something that we know already. Most of the genetic lesions are already at the time of NGAS, but they accumulate with the time, and when you do the analysis, in sequential analysis that we have done, you increase the number of cells with that genetic lesion. And this is nothing new, because already more than 40 years ago, Nobel reported that the tumor progression results from acquired genetic variability within the original clone, allowing sequential selection of more aggressive subclones. Sometimes we are obsessed about clonal selection with the treatment. The ideal treatment should eradicate all the clones, but we should be also concerned about waiting for treatment, allowing a clone to expand. This data has been the support for many other clinical trials that has been recently activated in the high-risk population. And as I already mentioned, I think the clinical trials that are ongoing should have, at the end of the day, two main goals. One is the safety, and the second, that is as important as that, is to try to eradicate the disease. For this reason, I think one of the most attractive is the KRD, a small number of patients, but as you can see, all patients achieve a complete response, and the outcome of this patient is particularly good. And in line with this, the Spanish group has designed a new ongoing clinical trial for high-risk smoldering in this population, we are only including patients transplant candidate, and as you can see, we are using exactly the same treatment as we use for the symptomatic patients: induction with KRD, autologous, consolidation, and maintenance. Then, where we are now, to treat, not to treat. We have evidence that survival in stage 1 is better than in stage 2 or 3. We know that in high risk, early treatment results in longer PFS and overall survival. We have criteria to identify a smoldering with 70% risk of progression at 3 years, the high risk, or at 2 years, the ultra high risk. And there is the dilemma of no treatment due to the risk of overtreating 30% of this patient. Can this justify undertreating 70% of the patient? I'm not sure. I think the doctor should decide together with the patients, after an appropriate information, whether or not to go in one of these clinical trials. But I also want to share with you another worry that I have. Everybody is concerned about early treatment in myeloma. Can we be overtreating? But in patients with early CRAB, just with 1 lytic lesion, 2 lytic lesions, we decide to treat. And the Spanish group have analyzed that these early myeloma with early CRAB are the long survivors, probably the ones that can be cured. In other words, we are already doing that. Probably we are overtreating some of them, but this is the way. What is this, my final slide, what is our personal position in this debate? I think we must continue to work in order to improve the accuracy of predictor biomarkers. In our center, we don't treat high-risk smoldering outside of clinical trials, but we do for ultra-high risk, the early myeloma, the new defined myeloma. And I think studies like the SKYRIDEX have contributed significantly to alert us that in myeloma, probably similar to other cancers, to delay the diagnosis and to delay the treatment is probably not the best option. Thank you very much. Is what with like the conversation with my mother.
From my grandmother.
So let's see what the lead is dangerous.
Thank you, Brian. I think that's very important to discuss with you. It's very difficult to follow. After Jesus, are you the second speaker in the debate? I said yes. So she told me, you will win, no problem. So, of course, we have to be cautious when we want to treat early myeloma, smoldering myeloma, to my opinion. This is an earthquake, in fact, and you know that the earthquake in myeloma was this paper published last year in the Lancet Oncology, and you can see that the culprit is Jesus. Not only Jesus, but he's one of the culprits. So because they have proposed to treat patients according to 3 new criteria: plasma cells of more than 60% within the bone marrow, free light chain ratio of more than 100, and more than 1 focal lesion on MRI. And we don't have to wait for symptomatic disease to treat the patient. So that's fine. So why did they select these criteria? So before we were treating only patients with symptomatic. I think that there's here some mistake, in fact, in the slides, no?
I did.
Okay, so they have selected 3 criteria to treat patients early in the course of the disease. So what are these 3 criteria? The first one is the 60% bone marrow involvement, and you can clearly see that the patients are progressing very, very quickly as soon as they have this 60% cutoff. The free light chain ratio of more than 100, once again, the patients are progressing very, very quickly to symptomatic myeloma. And also the one focal lesion on MRI patients in red are progressing very, very quickly to symptomatic myeloma. So I think that we do have some weaknesses here, because with the 60% cutoff, we know that it represents 3% of the patients. 95% are progressing very quickly. So this is a good marker. But with the free light chain ratio of more than 100, and that represents up to 15% of the patients, we have a progression in only 64% of the patients within 2 years. And with one lesion on the MRI, we have also 15% of the patients, but only 70% of them will progress very quickly within 2 years. So yes, we are going to overtreat some patients. Almost 30% of the patients that are not going to progress very, very quickly. So, and we were in the past requiring treatment for symptomatic myeloma and not indolent ones. And now we are going to treat earlier patients based on these three criteria: MRI, 60% of plasma cells, and the free light chain ratio of more than 100. So we are going to overtreat patients. And, well, this is the position of Jesus. No treatment due to the risk of overtreating 30% of the patients can justify the risk of undertreating 70% of the patients. And this is my answer. Is it necessary to treat 100% of the patients with high-risk smoldering based on the results of a single phase 3 study? So this is the study. And again, the last author, Jesus. This is the design of the study. 119 patients, treatment, control, Lendex, 9 cycles, maintenance, and in case of asymptomatic biologic progression, Dex could be added. In the other arm, no treatment until symptomatic disease. He showed you the PFS benefit. That's true. The overall survival benefit as well. But this study has many weaknesses and pitfalls, and you have to be informed, because that's very important. The study was not powered for overall survival. Dex could be added in the treatment arm at the time of biologic progression versus no Dex in the control arm. So progressive disease, PD, could be masked in the treatment arm. So maybe the PFS results are not those that are presented in the New England Journal paper. The treatment in the control arm was not defined. And maybe that's a bias in favor of the treatment group, because some patients in the arm without treatment did receive MP, and that's not optimal at all if you want to treat patients. And patients identified as high risk in this study are not identical to other patients identified as high-risk smoldering in other trials. And I'm not sure that other patients would have benefited in a similar manner for treatment. And what is the conclusion of a very, very recent paper published by Vincent Rajkumar, Marivi, etc.? They are claiming very recently that these results need to be reproduced by other studies. So, is it logical to treat all patients based on a single study? Well, it's up to you to think about this point. And what about the inclusion criteria? If we are now removing the early myeloma from smoldering, what is left? If we are removing these patients, in fact, and we are treating them immediately, what is left in indolent myeloma? What is the new definition of high-risk smoldering myeloma? So these new definitions are, to my opinion, to be clarified, because in the past we had this Mayo Clinic model, 3 risk factors, and of course if you have 3 risk factors you are progressing very quickly based on the M component, the percentage of plasma cells within the bone marrow, and the free light. This is the Spanish model. You are progressing very quickly if you are more than 95% of the plasma cells in the bone marrow abnormal, and if you have an immunoparesis. Okay, that's fine. But this paper is very, very interesting. This paper came from the Ola Landgren group. He looked at 77 patients with smoldering myeloma, and he tried to apply these two classifications, the Mayo one and the Spanish one, within these 72 patients. And the overall agreement is really poor. Only 22 patients were both high risk in the two categories. You can see that according to the Mayo model, out of 77 patients, 73 were non-high risk, according to the Mayo model, but 39 were non-high risk according to the Spanish classification. And for high-risk patients that need maybe to be treated, only 4 with the Mayo model, according to Ola Landgren, and 38 in the Spanish model. So the patients are not identical for sure. And this is another paper recently published in the GCO with various proposals to indicate what is the population of patients with a high-risk smoldering. And you can clearly see with many different criteria that's the progression rate within 2 years is ranging from 60 to 80%. So we are over-treating many, many patients, and the definition of high-risk smoldering is the following, according to Vincent, Ola, and Marivi. Many, many different variables. So we are not clear regarding the population of high-risk smoldering, to my opinion. So, okay, we can over-treat some patients, but we have to think about the toxicity of such a therapy. And Jesus, if I'm taking your slide, in the group of patients with indolent myeloma who did receive Lendex, we have 1 death from pneumonia. We have several grade 3 infections. We have also 5 cases of SPM. So that's not nothing. We have to be careful. So, of course, I fully agree. There are some benefits, possibility of cure, why not? Delay of symptomatic disease when we are treating early, okay. But there are some risks as well, over-treatment, toxicity, cost, and clonal evolution. Because, okay, Jesus, you are claiming that we can cure patients. This is scenario 1. If we are treating smoldering very early treatment, continued remission, cure. But what about these 2 other possibilities? We can provide a treatment, scenario 2, early treatment, but the patient will relapse, and relapse again, and relapse again. And we will treat him like we are treating symptomatic myeloma as a chronic disease. But there is also this possibility, scenario number 3, early treatment, we are selecting a very aggressive clone, and then it will be a nightmare to control the disease. So we are not sure that scenario 1 is the only one. Maybe scenario 3 should be taken into account. So, okay, Jesus, we recommend, that's your proposal, that patients with high-risk smoldering be offered clinical trials. That's perfectly true. 100% agree with you. But you are saying that patients with high risk who are being observed can be initiated on therapy without waiting for CRAB to appear. This is very pragmatic. This is very logical, but it is based on only 1 phase 3 study. It is very important, logical, but not evidence-based medicine. And what is the definition of evidence-based medicine? This is this. We are taking a decision with clinical experience. Okay, Jesus, you are one of the most experienced doctors in the field in myeloma, so you have a lot of clinical experience. But we should speak with the patient for patients' preferences. And to my opinion, that's also very, very important. We need data from research and strong and reliable data to take the decision. And I thank you for your attention.
three were concomitant. In other words, were diagnosed, prostate cancer, were diagnosed at the same time of entering into the trial. In the control arm, we have also one. Okay? Second is the pneumonia. I will not be surprised. You can die of pneumonia with multiple myeloma because you have immunoparesis by definition in this trial. Okay. One of the criticisms is that the trial was not powered for overall survival. He is completely correct. And for me, this was, as I mentioned, a beautiful surprise, because I think this is not a weakness, but a strength of the trial, because with a small population, we already have seen a huge benefit in overall survival. The second criticism, that many people have said that, because in the intervention arm, you were allowed to add DEX at the time of biological progression. Yes, this is correct. This was by definition in the trial. In the trial, we don't want to give the patient too much DEX, and we decided by design to put DEX at the time of biological progression in order to avoid, because it was an interventional arm, in order to avoid the symptomatic disease. That was the endpoint. The endpoint was active symptomatic disease. Then this is not a pitfall. This was the design of the trial. Now we are doing even transplant in this trial. The delay initiation in the treatment control. In several debates, I have heard that, look, you don't treat it in the control arm when they have a biological progression. I mean, what do you mean? What is the decision to treat a patient is when they have biological progression? No, when they have symptomatic progression. This is the standard of care. We cannot violate the standard of care in a randomized trial. And the standard of care was to wait until symptomatic disease. This was the reason we didn't treat patients in this situation. Then, about Ola Landgren paper. Ola has mentioned that there is only 28% agreement between the Mayo and the Spanish classification. He's correct. The two classifications use different prognostic criteria. More than 30 grams per liter, more than 10% plasma cell, and the ratio between clonal and total plasma cell more than. They are independent prognostic factors. If you want to have coincidental two classification, they should have the same prognostic factors. If you are using different prognostic factors, never will be coincidental. In fact, in symptomatic patients, not all patients with high-risk cytogenetics have advanced stage disease or renal insufficiency, but all are high risk. All identify high-risk patients, or in a smoldering patient. Not all the patients with more than 60% plasma cell have focal lesions, but both identify early myeloma. And here in the last part of the slide, I cannot see from here, but this allowed to a paper, very important paper published by Philippe. He has done the analysis of new staging system risk factors for multiple myeloma, for symptomatic, and 3 risk factors are independent. Identify a small population, 7% of the patients, but they are the ones that are ultra high risk with active myeloma. Then, I mean, the big mistake would be that they will be coincidental. You are using different prognostic factors, independent, and all of them can contribute to identify. Let me ask you, if you have a patient that has 17P, is a poor prognostic myeloma? Yes. If you have a patient with renal insufficiency and stage 3, but without 17P, is it an adverse prognostic factor? Yes. Then you don't need to have everything at the same time. There are independent prognostic factors. And I think I will stop here. No, not yet, because I should confess something. I would be probably in the same position if I would have been to say no, and probably Philippe to say yes, because both of us like Sophia Loren. Okay.
grandpa called me too. And since he likes very much to take care of the garden, the question was, the moment you start treating a patient, you become symptomatic just for the treatment. The other one is totally asymptomatic and is having a wonderful life, taking care of the garden. Did you make a comparison between the starting of treatment in the experimental arm from the starting of symptoms in the control arm? Because these are the two conditions when you move from a totally normal condition to a sick-driven physician condition or symptomatic myeloma.
No. Okay. We haven't done this analysis that I think is pertinent and of interest. We did a different analysis. We called the widows of the patient that died. And they were more. No, it's a joke. I think. No, I think it's very important because.
The joke is, on the other hand, you have a perfect normal person, so the comparison to some extent should be before.
No.
Between starting therapy and you become a sort of
No.
one and the symptomatic.
Antonio, I would fully agree with that analysis if the benefit would have been only on PFS. If the benefit would have been on PFS, I think the quality of life that you may impair in these patients due to the treatment would play a major role. But if you are increasing significantly the survival, moving, 20% difference in overall survival, I think what is my current position is that this should not be a real debate. I fully agree with what Philippe has said, that we don't know now by extracting the ultra-high risk what is going to be the benefit for the others. And in fact, this is what we are doing now in the new Spanish trial to analyze separately the ultra-high risk from the high risk, because I think it's an extremely important question. But at the same time, having this data, I think our debate should not be yes or not, but to generate as quick as possible, as soon as possible, information for these patients. Because if at the end of the day we are having the possibility of curing myeloma patients by early intervention, I think everything may change in this disease.
Okay. I don't see people rushing to the microphone. You haven't had a chance to call your mother or something. I don't know. Anyone want to raise any concerns or questions or comments? Oh, here we go. All right.
This is a little bit different than what I see in the work. When I get a patient diagnosed with myeloma who feels perfectly well, and this is smoldering, or this is just embryo's, first thing I say to myself is, this patient feels great. Can I make her feel better if I can even? What is she feeling better? With cyber D, she's going to be feeling better with red vaccines I'll take. If the answer is no, I say, well, then I have to come back in 3 months and see how she feels. Repeat all the studies. I think if you go stage 1 and 2 years later she's still stage 1, I don't think you're going to lose all that. The last thing I would say also is it neglects the concept of personal communication, that you could be treating a patient instead of the disease. The last thing I say is when we do this, we're neglecting the possibility of the change that are occurring in medicine now.
Okay, thank you for that. Reaction, Philippe, to this comment? Right, so very important point. So, Jean-Luc, you have a question.
As many of you know, I'm not from UK, but I'd like to address the question of the cost-effectiveness ratio. I think in this particular situation, when you have a strategy that is going to improve the progression survival, the overall survival, the cure situation, might be better in terms of efficacy. It's very important to look at the cost and the cost-effectiveness ratio in what we call, or what the English call quality, the number of years saved in good quality of it's very close to the question addressed by the doctor. I think it's, you can do that. I think it would be very important to have this idea of the cost-effectiveness ratio.
Yes, I think certainly a very important point. The first thing I would mention is that in the regimen that Jesus is proposing, it is a constrained regimen. You have induction and then you have a defined period of maintenance. So it's not open-ended, but has a definite cost. Do you want to comment?
Proportion of patients by early treatment, we will avoid all the cost of subsequent lines of therapy. That is what we are facing with all our myeloma patients. Less than 10% are cured with one line of therapy. And I think this is something that the hematologists, or myeloma doctors, we need to try to solve. For this reason, we are working together.
Yeah, so this is a financial argument that applies in several situations. If you can send a pure patients, they would no longer need therapy, even if it was very expensive for those first few people here. Antonio? Yes.
If you compare the start of treatment with one arm, the start of symptomatic myeloma with the other arm, and this is times 0 for both groups, you will survive. That's my point. And coming back to the point, because you have survived because you are including in the control arm 2 years of totally symptomatic life of this small population. If you take out that 2 years, your survival is amazing.
Okay. So we have a question over here on my left.
I have a question for Professor Gary. Apparently the approach that this kind of cure is going to have in the future looks like many drugs is going to have association after the initial treatment for multiple myeloma. But I'm not quite sure if just because all of us dogs myeloma, everybody has to go through association. So can you clarify about that?
Okay. The rationale for the new Spanish trial is that looking to the data that we have in symptomatic patients that early stage survive much longer than advanced stage of the disease with identical treatment. And we have identified that a group of patients that are potentially cured, in other words, progression-free at 10 years, correspond mainly to the early stage of the disease. It's not all, but it's a high proportion of these patients. Then we wanted to offer the same treatment because we have this schedule is being used also for the symptomatic. We want to use this same treatment in this early stage of the disease.
So we just have one more question, I think, that we're going to have to do that. So this gentleman right there.
And one of the reasons I think is that you just mentioned that the early stages as a result of the outcome. Now, the issue I
6 months. And untreated myeloma is almost, they say in the early days, you would die in 9 months. So, you're dead at diagnosis, which is kind of a sad thing. So how do you find the people in smoldering before you get to end organ damage? And, how do we get that done?
Right.
Because we're not doing it.
Well, this use of the biomarkers, I think that we're all supportive of that. And this is part of the earthquake that Philippe showed, is that we are moving in that direction. And those biomarkers are not good enough yet, but the best that we currently have.
You guys are great, I got to say.
Okay.
Everything that you do. But
all right. Well, thank you for that. I think we have to go ahead, unfortunately. We'll have to move to revisit the case and see if this discussion has changed anyone's opinion. So this is the same case, obviously a smoldering myeloma case. And the first question is, having listened to all of this, would anyone change their opinion? A majority actually said that they would do additional testing. So if we could just ask that question again. Okay, so the yes went up a little bit. If we can just go, I think we can compare the before and after. Okay, so the blue one is the after. So you did shift by 8%, Jesus, to have some extra testing done to clarify. If we would now go ahead, would you consider this patient a candidate for treatment? Yes, no, only in a clinical trial, or unsure. Let's see what people think about that now. Okay, my memory serves me correctly. We moved a little bit towards the clinical trials, which yeah, so if we look now to number 3, we've gone from 29% to 49% in clinical trials, although we still have about a third of physicians who are happy to consider direct treatment. So very interesting. We can't discuss further right now. So thank you for that.
You can reduce the dose.
So we're going to go ahead with the second topic. The second topic that we have is, should risk-adapted therapy be used for patients with newly diagnosed myeloma? And we, again, have two very experienced debaters who will be discussing this. Shaji will be debating with Antonio Palumbo. And if we can just go forward to the case. In this case, it's rather a simple case. It's a 68-year-old gentleman in good clinical condition with no apparent comorbidities, diagnosed with myeloma, discussing initial treatment options. He's having no pain, has a normal hemoglobin, IgG 3500, found to have several bone lesions. He's classified as ISS stage 1, no chromosome abnormalities, and a normal LDH. And so I would just alert you to the fact that I'm now going to show you a number of treatment options. And literally there is no 100% correct answer, but we would like you to pick the answer that maybe fits your perception of this situation and what treatment you would consider. In your current clinical practice, which of the following is your preferred induction regimen?
I realize that I use my papers. I should not have done. I should not have done that. He was able to take me later.
Okay, so we have a pretty this is quite interesting, especially for Philippe, I think, at ASH this year. We have a head-to-head comparison of VRD with VCD, and Philippe is actually presenting VTD versus VCD as an oral presentation, but we have strong representation for RD and some for KRD. So very interesting as a background for the discussion. So let's go ahead and I'd invite Shaji Kumar to come up and present the case for yes, risk-adapted therapy should be used as the first option for newly diagnosed myeloma. Welcome, Shaji.
Thank you, Brian, and good afternoon, everyone. I have to admit I didn't get a chance to call anyone. So I'm going to go ahead without any extra advice here. Now, I did ask Professor San Miguel to introduce the concept of risk stratification, and he's really nicely outlined how you risk stratify patients with smoldering myeloma and take the high-risk smoldering myeloma patients to treatment. And I think it's even more heterogeneous when you start thinking about multiple myeloma, and this is a very heterogeneous disease as we have understood over the past decade. Even though the survival of these patients have significantly improved, nearly tripled over the past decade, we still lose about a quarter of these patients during the first 3 years after diagnosis. So clearly we are dealing with a very heterogeneous disease. Now, one of the arguments against doing a risk-adapted therapy is that maybe we should just use the best treatment we have and give it to everyone. I would argue against that, because even the best treatment doesn't necessarily help all, and even with the very intense regimens like total therapy regimens, we still have a significant proportion of patients who die early on after their diagnosis. But at the same time, you also need to take into account the toxicity that could be attributed to very intense regimens in patients who may not necessarily need that. There are two important tools we need to have if you were to think about risk-adapted therapy. First one is we need to be able to identify risk. We need to be able to identify who is at higher risk of dying. And second, we need to have treatments that would preferentially benefit those patients with high-risk disease. Do we have those tools? I think even though we may not be perfect, we do have several tools at hand which can allow us to predict who is at a high risk of dying early after diagnosis. A variety of tools have been described that includes genetic abnormalities which are related to the clone. There are age and performance status factors related to the host, and there are obviously factors which are related to interaction between the host and the clone. One of the things that have really helped us in terms of risk stratification of patients with myeloma has been the identification of genetic abnormalities, which by using interface FISH, we can identify in the vast majority of the patients one or more abnormalities as shown here. Nearly half of these patients have trisomies, another half of the patients have translocations, some of them have both, and a proportion of patients have deletions involving a variety of different chromosomes. And we know these factors have significant implications in terms of outcome. Now, Dr. Palumbo recently published the revised ISS staging system, which incorporates some of the cytogenetics, as well as the old ISS staging system, which included the albumin, the beta-2 microglobulin, and the LDH. Now, this is a prognostic system, and I would argue that this is not a basis for risk stratification or risk-adapted therapy, because being a high risk in the revised ISS staging system doesn't tell you why you are high risk. Is it because of your FISH abnormalities, because of the LDH, or because of the high beta-2 microglobulin? And your approaches may vary depending upon what is the reason why a person is high risk. Now let's take a look at what do we have in terms of treatment that could actually modify the behavior or the natural history of somebody with a high risk abnormality. The best example, I will show you a few examples, and this is one of the earliest examples in the APEX study, where it was clearly demonstrated that if you treated patients with dexamethasone, patients with deletion 13 did not do well. However, if you treated them with bortezomib-based regimen, you actually have very similar outcome, showing that a drug can actually alter the natural history of the disease. Now, we have seen this again and again. We have seen it in the context of the 414 abnormality. The French have shown that if you use bortezomib as part of the induction therapy, you actually do improve the outcome. The similar results were seen with the total therapy 3, which incorporated bortezomib upfront and was able to show that a high-risk GEP population actually did better when bortezomib was included in the therapy. It's again been shown in the context of deletion 17p, where incorporation of bortezomib early on in the therapy by the Ho and German groups showed that if you used bortezomib early on, did tandem transplant, and continued with bortezomib maintenance, you can clearly improve the outcome of patients with deletion 17p, who are the patients in the blue here. Similarly, it has been shown that using tandem autologous stem cell transplant compared to a single autologous stem cell transplant, the outcome of patients with 17p deletion and 414 abnormality can be improved. Now, those are all clearly genetic factors. Now, there are factors which are related to the host that can also help us in determining what kind of therapy we give. On the left-hand side is a larger study which showed the implication of age. Older patients do have an inferior survival. On the right-hand side is a curve that looked at the eco performance status, and this is a Mayo data set, again showing that the outcomes can be quite different based on your baseline performance status. So Dr. Palumbo himself has recommended that we actually incorporate the age and frailty in terms of deciding what therapy we give. Maybe not necessarily what drug we give, but what dose of the drugs we give and what kind of combinations we give. Now, it's also important because about 20% of the patients with myeloma can present with some degree of renal insufficiency. And we know that reversing that renal insufficiency right away is critical for the long-term outcome of these patients. And by incorporating regimens that have bortezomib in them, we have been able to show that the renal failure can be reversed in a substantial number of patients, which then leads to an improved outcome in the long run. Now, specifically with the high-risk disease, we know that it's not just the drug, it's not necessarily the dose of the drug, but it is also what your goals of therapy are. And Dr. Paiva has shown that if you actually have high-risk disease, and if you get those patients to a minimal residual disease negative state, those are the patients who will do the best. So if knowing that somebody has high-risk disease is going to influence what drug you're going to use, what dosage of drugs you're going to use, what regimen you're going to use, and for what you're going to be targeting in terms of your goal of therapy. Now, this is not just something that I'm talking about. This is something that we practice on a daily basis. And this is what our MSMART algorithm says. Here we have patients who are transplant-eligible patients who are categorized based on their risk status, purely based on the FISH abnormalities. And in patients who have standard risk, we use a bortezomib lenalidomide dexamethasone combination. Again, you will see the basis of this recommendation from Dr. Dury's presentation tomorrow morning. And in patients who have high-risk disease where we are really targeting for a minimal residual disease negative state, we want to go with the regimens that have the highest response rate. So we have the tools today. We know myeloma is a heterogeneous disease. We know how we can categorize these patients into high risk, intermediate, or standard risk. And we know what specific approaches can actually mitigate the risk for the high-risk patients. Then, to say risk-adapted therapy is not needed would be like the ostrich. Thank you.
Okay, so we need to risk adapt, or maybe not, Antonio. Let's hear.
The answer is yes. How can you say no? The problem is, which is the risk adapted the strategy you want to follow. So we basically agree, but with few details. First issue. The issue is we define, and this is nothing new, but basically is a standard that I hope we will generally adopt it, because it's very important to have the same stratification among different studies in order to really see which is the difference. And the new stratification today is basically incorporated the three different parameters: ISS, chromosomal abnormalities, and LDH. Now this is a revised, is a meta-analysis that incorporated more than 3,000 patients. So my opponents show you some curve of 24 versus 18 patients saying that bortezomib overcome resistance of high risk. So here we are showing data on more than 3,000 patients. And the other comment I would do on this issue is that I totally agree. Myeloma is three different diseases. What we call high risk is a disease that is completely different from the low risk and is completely different from the standard risk. The high risk is someone that will have a remission of 6 months and will probably die very soon in 2 years. This is a different disease. Which is the problem? The problem is that until now we have run studies pulling together oranges and potatoes. In the future, probably what we need is to run studies with more homogeneous population, where you can see among the high risk, which is the best treatment strategies, among the low risk, which is the best strategies. Today, the mistake is that we compare low risk versus high risk, and this is where to some extent, I'm not with. So now again, 3,000 patients, and you look at the different options. You give IMiDs, you still see the same curve. You give proteasome inhibitors, you still see the same curves. So from a treatment point decision, the issue of saying I'm giving a treatment in one group and this will overcome the high risk potential of this group is honestly, until now, not true. Because independently from what you give, is IMiD, is proteasome inhibitor, here is transplant, is not transplant, you can see that the shape of the curve are absolutely identical. So today, as I was saying before, it's impossible to say I'm giving treatment A because it's better than treatment B in high-risk patient or standard-risk patient. Basically, independently from the treatment that we give, we are facing 3 different diseases that more or less are showing a different outcome. And now I'm telling something. This is a long discussion on land maintenance, yes or no. And you can see here 2 typical situations where you might change treatment according to stratification. Someone is in CR, and the other has a very good prognosis, no chromosomal abnormalities. So here I will say, if I can make a joke, that the dumb physician that doesn't understand too much will give the same treatment to everybody. And the curve is the yellow or the red one, according to what you see from the screen. But if you are smart enough to make a risk-adapted stratification, you don't give maintenance because you are in CR, you don't give maintenance because you are in a good prognosis, and you will see the curve that is the yellow one. So the difference is significant. On the same page, same story. Transplant, yes. Transplant, no. All patients in CR after induction. All patients in CR with in very good prognosis. You give transplant, it's much better. You don't give transplant, much worse. So once again, every time we have on a good number of patients the ability to stratify different treatment among homogeneous categories, CR patient from one side, good prognosis patient from the other side, you see the difference is still there. So where there is a stratification, and that's why I'm saying, yes, I agree that we do need the stratification. Today, the major stratification is basically age. And if we see the stratification we have basically 3 groups, basically very much homogeneous. All group is 30% of the total. 30% of young, 30% of we call fit, and 30% of frail. And basically the story today is that the stratification is autologous transplantation, yes, autologous transplantation for younger, fit patient, is certainly a free drug combination, and here differences are not, and I agree with the answer I saw, are not so important among different triplet, and you can see here basically bortezomib is present, dexamethasone is always present, and then you can add the chemo, cyclo or doxorubicin from one side, or IMiD, lenalidomide or thalidomide on the other side. And then we are facing something that will be probably more and more important in the future due to the aging of the population. And here I would say there is some change. Frailty is not an age issue. frailty becomes an age issue at the age of 80 years of age, not 75, provided no other comorbidities or what we call ADL of IADL condition are perfect. If I'm starting to be even younger, but with serious comorbidities or with mental abnormalities or mobility abnormalities, this is where I become afraid. For this condition, the two-drug combination, the oral administration, lower doses are probably the suggested condition because it certainly lowered the toxicity. And you can see here in several, at least 3 different randomized studies, the two-drug combination is not so different from the 3-drug combination. So my conclusion is simple. Please do not under-treatment standard risk patient or CR patient because we are probably losing much of our efficacy in this subgroup, because if we see what happened in the last 10, 15 years, we have been so effective in standard risk patient as we have been so ineffective in high-risk patients. So here, we might not increase that much in high-risk patients because we are ineffective today, but we are making the mistake of under-treating and being ineffective in a standard risk patient. And the other one is that age stratification is the common practice today, and I think today at present this is the major stratification as treatment is concerned. Thank you very much for the attention.
Okay, so perhaps I'll ask our panel right away to respond to this. So under treatment of standard risk, isn't that adapting to the risk? I'm not sure if I understand this. Do you want to come back? Okay. Oh, Shadi's coming back. All right.
I just wanted to thank Antonio for that great support for the risk-adapted therapy. I thought he was going to argue against it, but looks like he's finally come around to the fact that we have to do risk-adapted treatment. So I think he's made a very strong case for not using the revised ISS staging for risk stratification. He said it looks the same whether you treat with PI or with IMiD. And I am not surprised to see that because the ISS stage 3 could be stage 3 due to fish abnormalities, it could be because of LDH, it could be because of beta-2 microglobulin. However, what I was trying to say was if you had genetic abnormalities, you adapt your therapy to that. And I think he's also made a strong case for using risk-adapted therapy because he said if you use just the old-fashioned way of just using a melphalan-based therapy, a single transplant, and use Revlimid, the high-risk patients are not going to do very well, which I think we already know. And that is why we need to treat the high-risk patients very differently. So what I would leave with is when you see this, you actually have a choice.
Okay, well, that looks quite bad.
But I have a question. I have a question for my friend Shadi.
Okay.
Well, I totally agree that revised ISS is not a treatment decision for different options. But which is your genetic lesion you can use tomorrow in your clinic to drive different treatment decisions? Do you have some of them?
Absolutely. So I have a lesion 17 patient, 17p deleted patient. I would certainly consider a different treatment approach for that patient compared to somebody who just presents with trisomies. I would use more intense therapy. I would include bortezomib, and I would treat until progression. Whereas in I think we can get very good outcomes in those standard risk patients with trisomies with using the. We'll use the triplet of bortezomib and dex, but for a limited duration of therapy.
Okay, someone wants to launch into this discussion here.
Deletion 17 is by any chance part of the revised ISS?
Yes.
But that's one of the things.
Okay.
I just want to make a small comment. I think we do an excellent job predicting disease risk. No debate. I mean, Antonio showed us a wonderful curve, separate very nicely. I think our biggest failure is understanding drug risk. What I mean by that, can we predict who responds to Revlimid? Can we predict who responds to carfilzomib, for example? We have patient on your ECOG trial, Shaji, 10 years out, single agent Revlimid, and excellent survival. So I think we should put more effort in creating a biomarker therapy adapted risk rather than disease risk. I think this is what we should focus on.
Completely agree.
Yeah, very, very good point. Yeah,
we need
there are patients who respond very well to Revlimid and Dex and don't need triple therapy, for example, this kind of thing. Yes, so this is a risk adaptation, I think, Antonio. I'm not sure.
No, I completely agree with last comment. With the more, and I also agree with Saji at the end of the day. You see, today we do have prognostic factors. What we need is predictor of treatment efficacy. And this might come with the ongoing study on the mutational behavior, on the next generation sequence of whatsoever. Today are not available, and that's the limitation, maybe, and we hope to have it also for the cost of those drugs tomorrow to define which is the best drug in that given patient, in that given situation.
So are there any biomarkers that we can point to right now? Philippe, are there any biomarkers that you might think of to distinguish IMiD or proteasome inhibitor or to select the treatment?
No, I think that the two presentations are important because our goal is to adapt the treatment according to some prognostic factors that can be defined now more and more easily, I would say. But what is very important is that these prognostic factors are defined at the time of diagnosis. But we have also to follow the patient throughout the course of the disease and to look at the response, also to look at minimal residual disease. And we need, to my opinion, to incorporate MRD assessment within the treatment decision. That's very, very important. And we will hear during the meeting very important data on MRD evaluation by flow, by NGS, by PET-CT. So it is one treatment option is not only defined at the time of the presentation, but can probably vary over time according to this minimal residual disease assessment.
Right. So basically, the response to treatment is the best predictor of response to treatment.
No, I
Could
Let me ask one question.
I was saying that to not lose your faith. I think that the amount of knowledge that we are generating today with translational research is higher than ever. And for example, here at ASH, your group is showing that, the Italian group is showing that via high throughput cytogenetic characterization is possible to identify patients that will not respond to a standard of care such as VTD. I think that this kind of new information together with response assessment as Philippe has shown and as Shaji has shown in the slide will provide perhaps the power you want for risk certifying patients.
a final point, Jesus?
No, I think the debate is extremely important because as Philippe has said, it's not only the diagnostic criteria, it's also the follow-up criteria. Philippe is going to present in this meeting what is the outcome of patients that have residual disease detected by PET before going into the maintenance. And this is, it's a huge difference between the PET negative and the PET positive. We have the same data on the minimal residual disease in the bone marrow, either by flow or next generation sequencing. Then I think we need to integrate all of this. Let me put an example. Patients that have high-risk cytogenetics but achieve minimal residual disease negative enjoy much better survival than those that remain MRD positive with high-risk cytogenetics. All these patients die in the first year. Then I think it's very important just to conciliate everything when you are doing the follow-up.
Right, and we'll touch on this. Oh, one, yes, Gosta, final point.
Final point. I just would like to point out that Hermann Einzele and Knopp has a study where they show that del-17p poor prognostic, as a poor prognostic marker
can be completely overcome by allogeneic transplant. And they have a small study, but I think that is actually risk-adapted therapy. And there's no difference between the allos in the 17p in the autos without 17p. So I think that is really a reason for a study on this, more prospective study with larger material.
Thank you for that. I believe also the German group have data looking at single and double transplant related to high risk at ASH this year, so something to look at carefully. So I'd like to just go back to the case for this segment and just ask the question again, just to see if any of this discussion changed the way that you think about your treatment options. So which of the following is your preferred induction regimen for a newly diagnosed patient? Okay, my perception is it hasn't changed too much. It looks like, okay, so VRD picked up a few points and also VCD, so I'm not sure how to interpret that. The doublets were reduced in favor of the triplets, I think. Anyway, interesting. All right, well, thank you for that. So we're going to do you want to comment on this, Philippe? No? All right. So the third debate feeds right into this last discussion that we were having about the use of MRD and how to interpret results, perhaps guide treatment decisions. And in this case, in this particular situation, we are thinking about maintenance therapy. So should MRD be used to guide treatment decisions regarding maintenance therapy? And so, in this case, we have a gentleman, 63 years old, with myeloma, 30% plasma cells, a spike 3.5, normal LDH, ISS 2, so you can start to figure out the new ISS classification. Cytogenetics, 414 and 13 minus, but no deletion 17 and no extramedullary disease. So this particular patient has received induction with VRD, which was actually your top choice, and reached a CR after 4 cycles, which would be normally recommended. Continued in CR after subsequent stem cell transplant. Which is being presented at this meeting, the role of transplant after VRD. Received 2 cycles of VRD after the transplant, continued on maintenance with lenalidomide plus low-dose dex. Continued in CR. So there's a patient in CR after each type of therapy, induction, transplant, consolidation, and maintenance. MRD positive after induction, but achieved MRD negative after high-dose therapy. MRD negative was confirmed after consolidation and continued MRD negative for 1 year after maintenance. So doing really rather well. So, in your current clinical practice, what would you recommend next for this patient? Continue the maintenance with this MRD negative status, continue maintenance with lenalidomide monotherapy, so that would be lenalidomide without the dex, stop maintenance and observe closely, or are you unsure? Okay, so based on the MRD, the top choice is to stop the maintenance or continue the maintenance, but to stop the dex. It looks like very few of you would continue with the Len-dex combo, and most of you are fairly sure about one of those things. All right, so for this debate, we do have 2 experts on this. And so first of all, I'd like to ask Bruno to come up and present the case for using MRD testing to guide treatment decisions. So please welcome Bruno Paiva.
First, I'd like to thank Dr. Duri for the very kind invitation to participate in this debate and to stand for yes, that the role of MRD to help guide treatment decisions regarding maintenance therapy should be investigated. These will be the arguments of Professor Palumbo. He will say that MRD techniques are not ready for prime time, that their predictive value is not powerful enough, and that continuous therapy improves outcomes as compared to fixed duration of therapy. I'm sorry to say, Professor Palumbo, but in 2015, MRD techniques are ready for prime time. You have either next generation flow or sequencing, both reach a limit of detection of 10 to the minus 6, both are highly applicable in myeloma, and both are becoming more and more available. I would agree with you that even though the median PFS of MRD negative patients doubled the median PFS of MRD positive ones, and even though there is a 37% proportional increment in overall survival between MRD negative and positive patients, certainly the predictive value using first-generation MRD assays was not powerful enough. However, we have now next-generation MRD assays, and this allowed to identify a new patient population, here highlighted in the red curves, that have MRD of 10 to the minus 5. And this clearly improves the predictive value of MRD. This has been shown in Spain, in the UK, also in Italy, and also in the US. And here you can see progression-free survival curves according to patients' MRD status using next-generation MRD assays. I would agree with you that for sure there will be a role for imaging techniques such as PET-CT to monitor myeloma patients. But keeping in mind that PET-CT is positive in only 16% of smoldering myeloma patients, and by definition, the majority of these patients have 10% or more of plasma cells in the bone marrow, I would say that there is still a lot to be done to fully understand how to best combine a cellular with an imaging MRD technique. Now, because the patient has a 414 translocation, that is a high-risk cytogenetic abnormality, Professor Palumbo may say that the predictive value of MRD is not powerful enough. However, we can see here for both PFS as well as overall survival that the predictive value of MRD is powerful independent of patients' baseline risk, whether is it age, stage, or FISH cytogenetics. Then Professor Palumbo may also say that because the patient has no immune paresis, then the patient has a favorable biology, and therefore depth of response is not so important. We believe that patients with a favorable biology are the ones benefiting the most from intensive treatment strategies and reaching deeper levels of remission. In this slide, we can see the outcome of patients with a phenotypic MGUS-like signature at baseline reaching MRD negativity after stem cell transplantation. The median PFS is 10 years. The overall survival rates at 10 years are of 86%. And these results are based on a first-generation MRD assay. Certainly, I would also agree that continuous therapy improves outcomes as compared to fixed duration of therapy. But do all patients need continuous therapy to reach long-term survival? In other words, are some patients being under or overtreated. And we believe that the best approach to answer these questions is by implementing serial MRD monitoring in clinical trials using next-generation MRD assays, and to randomize patients after a period of maintenance into further maintenance or no maintenance according to patients' MRD status. This type of trial design will give two important answers. The first, if survival is equal between MRD negative and positive, then we would know that further treatment is beneficial for MRD positive patients. However, if survival is significantly different between MRD negative and positive, then we would know that further treatment using the same drugs was of no benefit for MRD positive patients. This type of trial design would still lead to two important open questions. First, if MRD positive patients can be spared from treatment because they have indolent clones. The second, if MRD negative patients benefit from further treatment. To answer these questions, we would need trials with a slightly different design. There is also serial MRD monitoring. There is patient stratification with next-generation MRD assays, but no randomization. There is treatment randomization into maintenance or no maintenance. This type of trial design will allow us to understand what is the best option for patients with persistent MRD after 2 years of state-of-the-art therapy. To stop treatment because it could be an indolent clone, to continue treatment to control the residual clone, or to change drugs because the same continuous treatment cannot control nor eradicate the residual clone. On the other side, this would also allow us to understand what is the best option for patients with continuous MRD negativity after 2 years of state-of-the-art therapy. To continue treatment due to late relapses, to stop treatment for a period of time until MRD reappearance, let's say 3 up to 5 years, or to stop treatment because many patients, particularly those with consecutive MRD negative results, may be operationally cured. In conclusion, there are at least 2 MRD techniques ready for prime time. The predictive value is powerful enough, providing MRD is monitored with standardized and high-sensitive techniques as defined in the new IMWG response criteria that is expected for the beginning of next year, and also that continuous therapy improves outcomes as compared to fixed duration of therapy, but does one size fit all myeloma patients? Professor Palumbo, you have been a pioneer in the design of clinical trials. And the question that we are facing now is whether you would like to continue pioneering the design of clinical trials by introducing MRD monitoring to help to understand its potential role to guide treatment decisions such as maintenance therapy. But I believe that by reading what you have written in the New England Journal of Papers in 2012 and 2014, I think that we already know the answer for this particular question. Thank you for your attention.
Okay, thank you, Bruno. So I think a strong case. What do you think, Antonio? Where can we move forward?
What can I do? You see, the glass is always half empty and half full. So here, to answer the question of my opponent, Bruno, yes, I would totally open for new trial, including MRD, but I have to say that you just gave me the answer of this debate. You propose one study, MRD positive versus MRD negative. Then you propose another study comparing all MRD positive versus MRD negative. So for 2020, when we will have results of those studies, we will finally know that MRD have a prime time. So basically, the conclusion of your presentation is telling that we do need study to define if MRD can be used to change treatment decision. And to some extent, this is my job, what can I tell you? This is what I agree, and I will try to be on the opposite side of the moon that Bruno presented. I completely agree with him. MRD is definitely a prognostic factor. As CR has been always a prognostic factor, MRD is only the most sensitive, is going down more in definition of the cytoreduction and is clearly a prognostic factor. I totally agree with you. But is this something important to change treatment? This needs to be shown. The first statement I will do is here, and this is somehow and is related to the story of the maintenance we just saw. Is a biomarker of cure? No. Don't make this mistake, because we have been already making the mistake that CR is a biomarker of cure, so I can stop everything because I'm cured, I'm in complete response. MRD is more or less more sensitive, but it's the same story. Look at here. We see in many early studies a flat curve at 24, 30 months. But if you still look and wait longer, you can see that even MRD negative patients at 3 years have a clear flat curve. At 7 years, they are in the 60% rate. If you wait 10 years, they go down to 25% rate. So first issue, MRD is not a biomarker of cure. Second issue, why? Simple. Because we can discuss on the sensitivities, -5. I would like to stress here, remember that immunofixation negative CR, what we see every single day is -2. So it's plenty of residual disease over there. With MRD, more sensitive, we go 4, 6, we go down, but still we have residual disease. And that's the reason why to say I can stop because I'm in a cure condition is honestly not true. Then the second issue, and this is probably less relevant, but we have to keep it in consideration, which is the plus or the minus of the two techniques. Flow, available in 100% of patients. NGS, 90, in the study. In the real life, maybe 80. You might lose 15, 20, 25% of patients. So you start to have a balance between the two techniques. NGS is more sensitive than flow, generally speaking, yes. And there is a need of standardization because one of the major limits of flow is that depending on the eye of your technician and the definition of the color cloud is seen on the PC according to the flow, you might have serious different results from one person to the other. So these are some of the pitfalls, but even one much more important pitfall is that bone marrow is not telling you everything about the disease because you can see here has been shown, and Philippe will present some very interesting data even in MRD, CR patient that have a CT PET scan, 30% of them is positive. So your bone marrow is negative, as happening in lymphoma, but someone else in your leg or in arm, you might see another focus. So the bone marrow by itself is not the definition of a negativity. On top of that, they didn't put actually my slide here. They left my old one. Someone did it. On top of that, there is an issue. And the issue is that when you start to evaluate PET CT scan, for PET, sensitivity is 50%. Specificity is 85%. We know already from the lymphoma that when we start to evaluate imaging, things are not that sure and secure. And also for the MRI, sensitivity is very high, it's 80%, but then specificity goes down to 40%. So even imaging is not that something that is totally reliable and secure. And to close, this is the data that is coming from the French group and presented by Philippe and the French group here at HASH Sunday. These are all MRD negative patients who receive VRD, autologous transplantation, consolidation with RD, and land maintenance, the new total therapy. You see what's happened? 30% of them has still CPET positivity, and you can see the difference in terms of curves. The one MRD negative with CPET positive, they are projected at 3 years at 50%. So you can see, and this is an important message that will come from this ASH, if you want, and from the French group, that probably the two methodology needs to go together, because you don't only need the bone marrow, you probably also need the imaging evaluation. Now another issue related to the pitfall of MRD. Blood. If you go to the blood, you lose 2 logs of sensitivity, because bone marrow is bone marrow, but the moment you are looking for circulating plasma cells, by definition, you lose 2 log of sensitivity. And in terms of treatment decision, I'm waiting with the MRD to see when I become MRD positive so I can restart my treatment. Here is a schema, of course, is a cartoon. So I have a bone marrow today, fantastically negative. Relapse is coming 15 days later. And then I wait 6 months for the next MRD. Meanwhile, I have every single month a free light chain that after 2 months is telling me that I'm in a clinical relapse. So this is another major pitfall for the MRD evaluation, because if we are not able to reach a peripheral blood evaluation of MRD, this is critical, especially for the evaluation of relapse. And now a next issue is clearly coming from the CML model. Is MRD seeing everything? Let's say it's just seeing the mature plasma cells. And if I have a progenitor cells that is much more mature, is the clone tumor? I don't see anything. So I'm basically looking at the mature compartment, the B cell mature compartment, and to make it more simple, I'm looking at the neutrophil. But if I have a blast over there that is already a tumor, I don't see anything. So that has been a major problem for CML, for example, because in the CML, they've been nicely, peripheral blood, BCR Robertson, the best marker you can find, and then they realize that even if everything is negative, maybe there is the progenitor that after a while is coming back. Last, but not least, a consideration. Can I make a joke, but very friendly? Yeah, these people are somehow cheating sometimes. They show you positive and negative MRD situation, 40% difference in survival because everyone is positive and everyone is negative. This is not the real life. The real life is that in one arm I have 10% MRD negativity, in the other arm I'm 20% MRD negativity. Is this giving a difference in terms of outcome? This needs totally to be defined. And you can see from this study that when you have a small difference in terms of response, this is not clearly translating in a difference of outcome. So with having said that, these are my conclusions. MRD is relevant. I completely agree with Bruno. We need to go through those type of studies. As we were saying before, we need studies in high risk, treatment A versus treatment B. We need the study in MRD negativity, treatment A, treatment B. Totally agree about that. But today, unfortunately, MRD is not yet a marker of cure. The standardization is on the way, but it's not just in our clinic. Imaging needs to be integrated. I think that is out of discussion. It's too important to have still 30% of patients with PET positivity in an MRD negative patient. And I hope we are not going through the CML model. All the CML people have been in those here to realize after we have fantastic MRD tools to realize that there is a progenitors that we are unable to see with our MRD tools. And this is basically a major problem in terms of residual disease. Thank you very much for the attention. And I hope.
All right, so thank you, Antonio, for that. I think perhaps we'll keep these conclusion slides up for a moment so Bruno can react to those.
In fact, there is
you have a slide
reaction slide.
Which reacts to it. Okay. All right. Let's go for that then.
I think it should be here. Yes. But before going to the slide, well, you are absolutely right. You started by saying that I gave the answer to the debate, that we would only knew the results in 2020. But I should say that your group has given the answer to your answer in the way that the GMM has shown that MRD reappearance clearly predicts overall survival. So if there is an MRD reappearance for patients that are not being treated, then you would have the signal. Then I would also make a point with the PET-CT. And again, we are on the same side. We both agree on the value of imaging. We have seen very interesting data, for example, on MRD after allogeneic stem cell transplantation, where an MRD negative result may not predict outcome because of extramedullary relapses. But despite that, you need to ask Philippe for the same slide using a next generation MRD assay and not a former flow assay. And then again, the 30% difference, and this is already here, the 30% difference in MRD rates. I think that nowadays, with 3 drug regimens, state-of-the-art therapy, if you really want those differences, you need to compare VRD versus VAD. But if I may ask you, is there a benefit, a clinical benefit for continuous therapy versus fixed duration of therapy? I would say that yes. And the proportional increment in overall survival was of 10%. We are seeing over 30% MRD positive versus negative. Then the issue of blood certainly is an issue. Everyone would like a non-invasive technique to monitor MRD. But as we will all have the opportunity to see in this ASH meeting, many different groups, the Spanish, the French, even from Japan, are showing results using the more sophisticated techniques that 3-year PFS rates are above 80, even 90 and so %. And this means that perhaps we can spare patients from consecutive bone marrow aspirates at least for periods of 3, 4, or 5 years, until we have that technique for peripheral blood. The last point is the progenitors. And many in the audience would know that this is one of the most odd and historical debates in myeloma, whether or not there is a progenitor cell within the B cell compartment. Some groups say yes, other groups say no, and the debate goes on for 30 or 40 years. I must say that even though the MRD story was not devoted to the myeloma stem cell, it does shed significant light. Flow focus on the plasma cell compartment, Whereas molecular techniques, either PCR, next-generation sequencing, they perform the sequencing in the whole bone marrow aspirate, that is B cells and plasma cells. Now, if there are myeloma progenitors in the range or levels as we can see in the literature, and because the authors were able to identify those cells 10, 15 years ago, the levels of the myeloma progenitors were in the range of 0.01, even 0.1%. This would mean that molecular techniques would be positive in all patients. And you would have significant discordance between flow that focus only in the plasma cell compartment and molecular techniques that measure all the cellularity. And this is not the case. I'm not saying that there isn't a progenitor. What I'm saying is that there is enough phenotypic and genetic plasticity within the plasma cell compartment, and so far this has been the clinically relevant compartment.
Okay. So I won't do this yet, so any further points to make? I think that Shaji, maybe you could comment. The IMWG has been working hard to revise the response criteria to integrate MRD, and the group has recognized the importance of imaging in addition to the MRD techniques. Maybe you just want to comment on that.
Sure. No, I think both Dr. Palumbo and Bruno has made very strong points about the relevance of MRD testing in this disease. And we all understand that it is a powerful prognostic factor and it can predict outcome. What we really don't know is whether acting upon that information is going to make a difference or not. So one thing I think there's a consensus among everyone is that MRD assessment should be routinely incorporated into clinical trials. Now, to do that, we have to have some kind of definition out there. And that is what the revised International Myeloma Working Group response criteria is going to be showing is, okay, we're going to define what is a MRD negative status and what is a imaging MRD negative status. So we want to have those definitions out there, the imaging based on PET scanning and the molecular marrow MRD based on either next generation flow or a next generation sequencing method, but defining them so that we can incorporate them into clinical trials, fully understanding that those definitions would change in the future once we gain more information about it.
Right. But there is one new category, which is sustained MRD, which includes MRD negative by flow or sequencing plus imaging, which I think is a key point related to some of the discussion points. Jesus, you have a comment?
Yeah. I think in the myeloma, we are still far away from other diseases that are using MRD for monitoring the disease, such as ALL and CML. But hopefully, we will move in the same direction. I think one of the beauties now in CML is that there are clinical trials in which you stop the drug, you reinitiate as soon as the patient develops again a PCR positivity, and I think probably in the near future we will move in that direction, but I mean, we're still far away. And regarding the minimal residual disease techniques, I think in this symposia, and I think it's very important for all the audience, we have shown that when you analyze disease in multiple myeloma, you need to analyze the bone marrow and outside the bone marrow, because both of them are complementary, really. And this is what is going to be shown by Philippe and the French group in one of the most important presentations in this meeting. I mean, and you would expect the same results? No. I mean, there are patients that will have residual disease in the bone marrow with a PET negative and the other way around. This is the reason why you need both. And another educational comment is about the sensitivity of the minimal residual disease techniques. If you talk about the bone marrow, the people is debating between PCR, next generation sequencing, flow, next generation flow. I mean, and if you compare a low flow versus a next generation sequencing is most sensitive. If you compare a low PCR assay versus a high sensitive flow, flow is more sensitive. We are talking now, and this is good for everyone to know, about the last techniques that both of them, the flow and the molecular, can detect one malignant cell among approximately 1 million normal cells. And this we have done with the same degree of sensitivity in parallel. A group of patients and are identical. And this is something that also is very good because labs will have the opportunity to choose one or the other. And for the PET is going to be also something like that in the future because we are using glucose, but there's people that is using also methionine that probably may have even more sensitivity. I mean, there is an evolving field, I think, for everyone.
So maybe a couple of points. That at this level of sensitivity, it's important to emphasize that the test needs to be quantitative at that level, where you can actually have a numeric result at those levels. And then at ASH this year, Bruno, there's also some information about the peripheral blood. We've emphasized several times that we need to have a blood test, but there are some data looking at myeloma in the blood. Do you want to comment on that briefly?
I don't know if this is working.
Yeah, it's working.
I would say that so far the data is telling us that if the patient is under therapy, those cells that circulate in the blood are truly chemosensitive and they rapidly go away. We do need prospective data, which is not yet available, to see if by monitoring the blood on patients off therapy, if the cell emerges in blood prior to the immunofixation, and this is informative to predict early relapses. But what we are seeing here in ASH is that definitely the sensitivity of the new assays to detect cells in blood is extremely high. In fact, it's now in 100% of all myeloma patients. So again, emphasizing that the assays are ready to detect cells in such low numbers. But we need to incorporate these assays in the trials to understand if this can be predictive among patients off therapy.
A final comment, Philippe, yes?
Yes, in fact, I think that we are making a lot of progresses. We have new drugs approved very recently. We are now able to do new imaging techniques and MRD evaluation, etc. But I think that we are really far behind of non-Hodgkin's lymphoma, for example, with PET. In non-Hodgkin's disease, we know perfectly how to adapt the strategy according to PET positivity and PET negativity. This is not true in myeloma. For MRD evaluation, and we have to standardize the technique. There is a joint effort in Europe with the Italian group, with the group from the Netherlands, with the French group to have a sort of Deauville scale on myeloma. That's very important. And also the MRD evaluation, either by flow or by NGS, well, we are really far away from what we are doing in acute leukemia. Because some patients, in acute leukemia, patients are treated in academic centers. And all of them are in university hospitals or things like that. And we are doing some evaluation of MRD. And as soon as the patient is not reaching the cutoff, he can proceed to allo stem cell transplantation or, on the opposite, to consolidation, etc. In myeloma, that's really, really different. And a recent paper was published by Ola Landgren. And he looked at the flow evaluation within many different US centers and saw a huge discrepancies. The technique was not identical, the sensitivity was not identical. So we have to propose standardized techniques that are reliable, and then we will be able to treat patients according to, well, let's say real data. That's very important.
And so this is actually part of the new criteria recommendation. So I think we need to move forward. So unless there's some really pressing comments, let's revisit the case. As a patient who achieved a very, very good response with MRD that was sustained after maintenance. And the question was, should the Lendex be continued? Should it be just Len alone? Or would you stop the maintenance? With this discussion, have you changed your opinion at all about what you might do? If you could vote on this one. Okay, so that looks almost identical to me. Yes. So really interesting. Very, very little change. With the MRD negative, people are pretty much in favor of stopping or continue with the lenalidomide but without the dex. Interesting. But nobody, I guess it was an interesting discussion, but people didn't change their recommendation. All right, well, thank you for that. All right, well, we are going to move into the final debate for this, and this is a very, very key type of decision process as we have all of the new emerging therapies. How do we integrate these new emerging therapies into the treatment paradigm that we currently have? And so this question is about, if we have new therapies, how quickly should we use them in a newly diagnosed patient, or should we continue to use them in the relapse setting where they have mostly been recently approved? And so debating this, we have Shaji and Philippe, and Shaji will make the case that we should look to include new therapies into frontline therapies, whereas Philippe, I think, will again be on the cautious side. So let's hear Shaji first. Please welcome Shaji again.
Thanks, Brian. So I get to go out on the limb for both the debates. So I think this is a very pertinent question. Now we have 3 new drugs that was just recently approved, and the question at the top of all of our minds are, how do we integrate these new drugs into the current treatment paradigms? So I guess we should do the case first. I'll let you do that.
We should do the case first. Yeah, so I'm so sorry about that. Yeah, so as far as the case, what we picked here is a lady with newly diagnosed myeloma. And for this lady, you'll see that she's 45 years old. She has stage 3 disease, 70% plasma cells in the marrow. And what is perhaps key for some of the discussion is that on the FISH testing, this patient had a 414 and a deletion 17 in 90% of the plasma cells. The LDH was also elevated, so you can see that this is a newly diagnosed young patient with high-risk disease. And so as a baseline for the discussion, we are asking you, for this kind of a patient, what would you pick? And you have the 6 choices there: Lendex, VTD, VRD, KRD, or you'll notice that we have also included ixazomib, even although this is actually only currently approved in the relapse setting. So, okay, so you can see that the choices are for a triple approach, either with Velcade or carfilzomib combined with Revdex as the top choices. So you can use that as your basis going forward. So Shaji. Oh, we have. Oh yes, the second part. I'm sorry. Yeah, the second part is. Something that we added because of the approvals of the new therapies was to see what is the setting, the optimal place for these emerging monoclonal antibodies. We have daratumumab and we have elotuzumab. If you had an open choice to use daratumumab or elotuzumab, where would be the optimal place to introduce those? Newly diagnosed, early relapse, salvage, or unsure? All right, well, we're pretty well split on that. So this should be an interesting debate, finally, completely split against the best place to use these new emerging antibodies. So finally, Shaji, go ahead.
There you go. Thanks, Brian. So, I think, we should, this is something that is going to be debated for years as to how we're going to be incorporating some of these drugs. But what I would like to do is to make a case for early incorporation of these new drugs in the upfront setting, particularly for certain groups of patients. Now, we know the survival in myeloma has really improved over the past several decades, and we all hope that the future would be this. But to get there, we first need to understand how we go to where we are today. And there are several reasons why myeloma patients are doing much better today than what they were doing 15 years ago. We have a better understanding about the disease biology. You heard from Professor San Miguel and Dr. Morrow the concept of early intervention. We have more reliable risk stratification systems that we talked about. We have early and use of effective novel drugs, rational combinations and risk-adapted therapy, and the concept of prolonged therapy. But one of the critical things is the early use of effective novel therapies. Now, what does that give us by the early incorporation of novel therapies? One of the striking things about myeloma, what has changed over the past decade, is the reduction in the early mortality. Even in the phase 3 trials using dexamethasone as a control arm in the early 2000s, we had almost 11% of patients dying early. But if you look at some of those, when you incorporate novel agents in the upfront setting, we significantly reduce that risk of early deaths. Now, that is phase 3 trial setting. But even in the community, based on the SEER database, we can clearly demonstrate over the past 10, 15 years, we have made a significant impact on the early mortality in this disease. And a key factor has been the early incorporation of novel therapies. What else does novel therapies give us? We know that the response rate and the depth of response can be significantly improved by incorporating these new drugs in the upfront setting. As shown here, again, you can see that patients getting some of the newer therapies in combination in triplets, we are seeing response rates in 100%, almost 80 to 90% of these patients can get a very good partial response or better. So clearly, there is a role for these novel agents in inducing deeper responses. But why do we care about those early responses early on, or deep responses early on? What we have learned over time is that with each subsequent line of therapy, as patients relapse and go on to different therapies, we have less and less response rate, and these responses actually last for shorter and shorter duration. Now, why does this happen? Some of the elegant studies that have been done over the past decade has clearly given us an idea of what happens to the myeloma clone over the disease evolution. There's clonal evolution that happens. New clones that are resistant to different therapies come and go, and this likely contribute to that diminishing effectiveness of the therapies as we go down the different lines. So what we have done successfully over the past decade has been continuing to build on a solid foundation. One of the good examples is the total therapy regimens, where they have Dr. Barlogi has progressively added the new agents up in the upfront setting. In the green here, we see the addition of thalidomide. Here you see the addition of bortezomib. And clearly you see that the addition of novel agents early on in the therapy has made an impact not only in the progression-free survival, but also in the overall survival. Now you will hear from Dr. Dury tomorrow in the morning presentation the results of the phase 3 trial that looked at the combination of bortezomib, lenalidomide, dexamethasone versus lenalidomide and dexamethasone. And he's going to tell you that there's going to be was a significant improvement in the progression-free survival and also in the overall survival when patients with newly diagnosed myeloma was treated with the triplet compared to the doublet. Now we also have at least 3 phase 2 trials that have looked at the combination of carfilzomib, lenalidomide, and dexamethasone. And this example is the one that was presented by Dr. Zimmerman at ASCO last year or earlier this year, which showed that the combination of carfilzomib, lenalidomide, and dexamethasone can give high response rate and can also give very deep responses, including MRD negative state. Now, one of the arguments always has been, well, if we use up all these drugs in the beginning, we are going to be at a disadvantage later, and we are not going to be able to salvage these patients effectively. And Dr. San Miguel here from his VISTA trial has clearly shown that addition of bortezomib to melphalan and prednisone not only improved the overall survival in the initial diagnosis, but it did not in any way hamper the outcome after starting on subsequent therapy. So saving these new drugs for later on may not necessarily always be the right thing to do. Now, there are certain groups of patients in whom these arguments are particularly important or particularly relevant, and that is the high-risk myeloma. And we already talked about this in one of the earlier talks, that patients with deletion 17p don't do well, but if you actually treat them with a bortezomib-based regimen right from the beginning, give them tandem transplant and continue with the bortezomib-based therapy, you actually can make a difference to these patients with 17p deletion. We also know from Dr. Power's data that not only the treatment strategy, but also treating these patients to an MRD negative state by using very effective combinations can actually make a difference to these patients in the long term. So let's take the example of the bortezomib lenalidomide dexamethasone. Dr. Richardson did this phase 2 study with about 66 patients back in 2008. That was when he presented this, and showed that the triplet actually gave you a 100% response rate and a 67% very good partial response or better. And Dr. Dury is going to present the results of this trial tomorrow. And it took 8 years for this phase 2 data to translate to a phase 3 trial to actually demonstrate that there's an improvement in overall survival. There's no doubt we need phase 3 trials. They are the gold standard for deciding that one treatment approach is better. The question we had to ask ourselves is, can we wait for phase 3 trials to actually give us mature data? There's no question phase 3 trials need to be done. The question here is, do we wait for the results to be actually, should be shown? I would, during these 7 years, that would have been 150,000 patients with myeloma diagnosed just in this country. And if you consider 20% of them have high-risk disease, it's possible that some of those patients may have had a different outcome if you treated them with a triplet versus a doublet. Now, we always make the argument, why don't we want to incorporate something right away without the phase 3 data? The whole concept of primum non nocere, do no harm. I totally agree. I think that should be on the top of our minds. But how do we explain that to these 25% of patients who die in the first 3 years of their diagnosis? So I think it's very important for us to actually take the data from those well-done phase 2 studies where it clearly demonstrates that incorporation of a new drug in the upfront setting actually is safe and is effective, and use that data at least for these high-risk patients and incorporate them early on to continue to improve their outcomes, which we know currently is fairly dismal with everything that we have. So it boils down to the risk-benefit. So I think these patients with high-risk disease, there's clearly a lot to lose, and we already know that it's unlikely to harm these patients if we have good phase 2 data. So I think as long as the phase 3 trials are ongoing, we should take that leap of faith and treat these patients with the newer drugs that we have. And that is exactly what we do with our MSMART algorithm. We actually look at the high-risk patients, and our current recommendation is that we take the high-risk patients, treat them with a combination of carfilzomib, lenalidomide, and dexamethasone, even though there is no phase 3 data for this. But clearly we know there at least 2 or 3 phase 2 trials have clearly demonstrated that this combination is highly efficacious. Now, Dr. Moreau himself has looked at the concept of adding these new drugs like the monoclonal antibodies to the triplets, and he presented this data at the last ASH, again in the setting of a clinical trial, again exploring the possibility of adding these drugs to the upfront setting. So I would like to conclude by saying that the first intervention that we do for myeloma probably gives us the best chance to control the disease in the long run. And this is particularly true for the high-risk disease. Phase 3 trials absolutely needs to be done, and we need to go with the phase 3 data. But we should also effectively use the information that we get from well-done phase 2 trials. And particularly for high-risk patients, I don't think we should wait for phase 3 results as long as those trials are already ongoing. We know the phase 3 trial results take a long time to mature and give us information, but techniques such as the minimal residual disease testing, if implemented as part of these clinical trials, may be a good surrogate marker for early readout and could help with this dilemma. So I'll stop there and thank you.
All right, so what do you say to this early use of new agents, Philippe?
So I think that's very important to use the drug with the evidence that they are really effective and not toxic at all. So we have to be careful with the phase 2 data. And I think that, for example, for patients that are eligible for stem cell transplantation, we are proposing these triplet drug induction regimens. And why are we proposing them? Not only in Europe, but also in US. And this is the very last version of the guidelines published in US something like 1 month ago. And Shaji, you are here, one of the authors, so that's very important to consider that you are part of this paper. So what are the preferred regimen for patients that are transplant candidates? Category 1, based upon high-level evidence. And then you have Veldex, you have PAD, you have VTD. So Veldex is a backbone, and you can add something to Veldex. And the most important evidence is coming from meta-analysis, from patient-level data on phase 3 randomized trials. And we have here, for example, 4 randomized phase 3 trials comparing Veldex versus VAD, VTD versus TD, another study of VTD versus TD, and PAD versus VAD. And in all of them, bortezomib-based regimens are better, improving the complete remission rate, and all subgroups of patients are benefiting from a Veldex-based and very often triplet combination. And most importantly, it translated into a better progression-free and overall survival. So no doubt that we need to use triplet bortezomib-based induction treatment based on these phase 3 data. And we have to work on the improvement of the knowledge. I think that many of you are using VCD in the routine practice. That's widely used in US, widely used in Canada, in Germany, etc. VTD is widely used in Spain, in Italy, in France. So we wanted to have reliable data. What is the best regimen? So we did a phase 3 randomized trials on a very large number of patients, 340. And we are clearly showing that the VGPR rate is increased with the VTD regimen, combining NIMID plus a proteasome inhibitor. And to my opinion, VTD should be the standard of care if you want to use a triplet that is not very expensive, for example, with the addition of lenalidomide instead of thalidomide. So this is evidence-based, based on phase 3 data, and I think that we have to be careful with some phase 2 study. And Shaji mentioned the RVD results published a long time ago, and he said that we don't have to need phase 3 randomized study because it took 8 years. Well, it took 8 years in US. I'm sorry to say this, Shaji, but in France or in Italy or in Spain, it can take 2 years to have the results. So back to this RVD study. RVD, 66 patients. Phase 2, 35 patients. And Paul Richardson nicely showed that the response rate was very, very high. Okay, and then in US, many doctors abandoned stem cell transplantation based on these results. So that was a big mistake because they said, okay, RVD, 100% of response, VGPR rate, 74% of response, you can abandon frontline stem cell transplantation. And Shaji, you published this data. Early versus delayed stem cell transplantation, no difference. So yes, you should abandon. This is not a randomized study, that's a retrospective analysis. And then Dr. Jakubowiak in Chicago, he did a very good job, KRD, without stem cell transplantation, nicely showing very important stringent CR rate. And people are really confused. They are saying, okay, the PFS is excellent, so should I use KRD systematically for my patients? Okay, why not? That's probably a good regimen, but we don't have phase 3 study showing that it is superior to another regimen. And Shaji showed a KRD stem cell transplantation. Phase 2 again, small number of patients. So what should we do? KRD alone or KRD plus stem cell transplantation? We still don't know because we don't have a phase 3 study. So, okay, in France, we decided with the French group to demonstrate clearly that we needed early stem cell transplantation. RVD, 8 cycles, that's the US approach, let's say. So we did the French approach, RVD, stem cell transplantation, and RVD consolidation. And the results will be presented in 2 days by Michel Attal. That's a very, very important study because based on this RVD 8 cycles, many doctors abandon frontline stem cell transplantation. So what are the results? Michel showed the data at the last International Myeloma meeting in Rome. And the high-dose treatment arm is associated with a better progression-free survival. So we have to be careful. We need phase 3 data, and we have to be careful with phase 2 data only. And all subgroups of patients are benefiting from early stem cell transplantation. And some of you in the room are proposing to use daratumumab frontline now, and that was 27% of the audience. You want to use this drug very early on. And Shaji, you mentioned that I have proposed a VTD DARA phase 2 study. Yes, the goal of a phase 2 study is to demonstrate that it is safe. And we have demonstrated that VTD DARA is feasible, is safe. And then we are moving in France, together with the Hovon group in the Netherlands, in this randomized trial comparing VTD and VTD DARA in the context of stem cell transplantation. So I am okay to use new drugs up front, but we need clear data to demonstrate that the new drug is adding something. And to be honest, Shaji, we will enroll 1,000 patients in this study, and it will be done in 1.5 years, for sure. So let's move now to the elderly population of patients. And what is the frontline proposal, the frontline treatment, VMP or Lendex, for example? So, and this is also true in the US guidelines, category 1, VMP, MPT, or Lendex. So VMP is well established, randomized, prospective study, very large number of patients, Jesus as the PI, so a very good study for sure. And there is an overall survival benefit at the end of the day, so VMP, no doubt. Lendex, very good study, very large study, very high number of patients enrolled, 1,600 patients comparing MPT versus Lendex, fixed duration, Lendex continuous treatment, and PFS data are clearly showing that Lendex is a very good option, and the data were updated at the last ASCO meeting. The PFS of Lendex continuous is really clear, and it translated into a better overall survival. So I'm really okay with this data, and Lendex should be considered as one of the best standard of care for our patients. So if we want to improve on this treatment, okay, we have maybe to use ixazomib. You want to use daratumumab. You want to use elotuzumab in the future. But are you sure that the addition of ELO to Lendex frontline is going to impact on the overall survival of your patients? Are you sure of this? I don't know. The future is to have phase 3 randomized trials to demonstrate that we are improving PFS and OS. If you want to use an MP-based combination in your elderly population of patients, okay, VMP is one of the standard of care, so Carfil is a possibility. So you should compare Carfil MP versus VMP. That's the Clarion study, and we will have the results of this study next year. You want to use DARA upfront? Okay, why not? But you should add DARA with VMP in a randomized fashion to be sure that you are improving the PFS and the OS. If you want to use a Lendex-based treatment, you should randomize as well Lendex versus ixazomib. This study is ongoing. You should randomize Lendex with ELO, and we will have the data. And you have to wait just a little bit. And Lendex versus Lendex DARA, this study is ongoing. So as soon as I will have the results of this phase 3 study showing a PFS benefit, maybe an OS benefit, I will be really comfortable to use all these drugs up front, but not today. We need to wait a little bit. Be patient. Thank you.
Okay, in this case, I think two very strong arguments. Do you have any initial reaction, Shaji?
So I just wanted to remind Philip that it did take us 7 years to do the SWOG trial, the VRD versus RD, but we have an answer which says VRD is better than RD. IFM took 3 years to do the 1,000-patient trial and came back with an answer we already knew, that was transplant early or late is the same. So I think the important thing is actually demonstrating the answer for the phase 3 trial. But I think, again, we kind of diverted a little bit there in terms of the point of discussion, which is the incorporation of novel agent up front. And I think I still want to just point out that the IFM study was not intended to and does not tell us whether transplant is needed or not. All it tells us is that the transplant can be given early or late with no difference in the overall survival. But clearly there's an improvement in PFS by doing transplant early, which is not different than what the previous trials have already shown us. Okay. So I think, again, I totally agree with Philip that our practice should be driven by phase 3 trials. But I think there is a role for interpreting the data from the smaller phase 2 studies for the patients who we are not able to give, the therapy that we have today is suboptimal, which are the high-risk patients.
So any reaction or comments from the audience? Use right away or wait for phase 3 data? Okay. I think we should just go ahead and ask the question again. See if you... Oh, there's a question here? Yes. Okay.
When you moved from smoldering setting to newly diagnosed and relapsed and refractory, you dropped the patient preference from your equation on how you determine treatment. Do you not think patients play a role in the type of decision for when you don't have decisive data in some of your recommendations?
Right, so okay. Come back. Don't go away.
Okay, it sounds like you might have a direct answer.
Absolutely yes. Because it's of course, if you ask me what to do, I tell you what I believe is what is evidence. If more than what I believe, what is evidence, but you will decide what to do, not me. So from that point of view, this is totally out of discussion, if I understood correctly your question.
If I may, the last slide of my talk during the first debate, that decision on a specific treatment should be based on the experience of the physician, the patient preference to discuss with the patients, but also evidence-based. That's, of course, a mix of these three important factors.
Yes. So I think that one of the more urgent aspects for patients would be, for example, in the high risk, which was actually this case, where we don't have phase 3 data for a better therapy. But I noticed that already in the M-SMART, there's a recommendation for KRD. So this would be sensible, possibly related to a patient need. Yeah. How do you think about this, Jesus? Oh, have a question. Okay.
So thanks for these interesting debates. And this is a general question actually for the clinicians on the stage. So I've heard a lot the word cure during these debates so far. And this has been a big utopia in the field of myeloma, to actually tell a patient you're in fact cured from your myeloma and it's never going to come back. So what do you do nowadays with your early disease, low-risk myeloma patient in the absence of allogenic stem cell transplant? Do you tell them that they have a chance to be cured? And when you draw the line, how long is a follow-up for somebody that is in complete remission to tell this patient you will die of something else but not your myeloma?
Okay, this is a multi-part question. I think the first thing we've touched on a little bit for a good risk patient, early risk myeloma patient.
Can I answer?
Yes.
I don't know.
I accept that.
That's honestly the best answer. I believe there are two two basically ideas among experts. One idea is, yes, we might start curing a patient, and you might say that, I would say 7 years MRD negativity could be an endpoint. And this could be to some extent one answer. The other answer is that maybe myeloma could be like breast and CML. So we are dramatically improving survival, and this is honestly, you know, we have been moving from 18 months to 5-6 years of remission duration. But to some extent,
patient cure has a different meaning
I
than
do
prolonged
understand,
survival.
but
So
no, I do
it's a
understand,
big
but
word, you know, to say to somebody. So do you have data to actually support that you can cure people right now with myeloma?
I don't think we have the data. I mean, I don't think prospectively we can, you know, we cannot tell a patient on his or her face that you are cured. I don't think we are at that point. That's where prospectively we want to look at endpoints, like, you know, if you're MRD negative continuously for 5 years, what does that translate to your myeloma coming back or the chance of it ever coming back? Retrospectively, we could say if you have an 80-year-old whom you diagnosed with myeloma today and it never came back for 10 years and died of coronary artery disease, yes, we can tell retrospectively we probably cured that patient. So it's all in the context of where in the, what age you're talking about and how long things are going to be in control.
But I think we probably do agree with the 7 years, so that, for example, in what's called the CURE trial, the CAESAR trial, there is actually 2 years of treatment, and then the endpoint is 5 years after that. So it would be basically, if you're still MRD negative at the 5-year post-therapy, we would be pretty optimistic. But we do have some data. There is an IMWG project looking at over 6,000 patients, looking at what you can expect if you are still in CR for that length of time, where you can predict that the likelihood of relapse does drop. But I think your first comment, Antonio, is correct. We don't know at this point. Okay, so let's go to the final question to ask again. Oh, we don't need these. We were going to talk about these, but I don't think we should at this point. We wanted to update you on the new drugs, but so let's just revisit. We basically have a newly diagnosed young patient with high-risk myeloma, and we are asking you in your current practice which of the following regimens would be your first choice, and it would be using combinations with phase 3 data. It would be using some combinations without phase 3 data. Okay, so my perception is maybe it moved a little bit towards, yes, KRD. But the triplet with the IMiD and the proteasome inhibitor, definitely the top choice. And then there was the second part to this question. What is the optimal place to use the emerging monoclonal antibodies? And so this was split before, but it'd be interesting to see your reaction after our discussion. So if you can answer this question again. Okay, so I think there's a little bit of a shift away from newly diagnosed and toward early relapse, but still a split opinion here, with a little bit more unsure with this question than most of them that we've asked so far.
That's a nice answer, honestly.
Okay, so this is the end of our formal session. I would ask if, first of all, if our panel has any final comments, any words of wisdom, and if anyone has any final comment from the audience.
No phone call coming from Spain?
Final comments from Spain? Did you
No,
call
no,
your...
no.
I think he
No
called his
phone
mother.
calls
Maybe called his
coming
mother
from
again.
Spain.
No.
No. Philippe is invited home.
All right. A family visit. All right. Well, we do hope that you found this useful and also enjoyable. It's the beginning of a long meeting, so hope you get a lot of information. So thank you for being here. One last thing, if you could turn in your evaluation forms on the way out, we do appreciate that. We do need that feedback. Thank you. Oh, I think it was good. I think it was good. Yes, I think it was good.
The best was the first one.
It was very good.